Now coming to the heart sounds and murmurs. This is one of the very most important topic, and recently there has been a trend of questions from this heart sounds. So coming to heart sounds, we have already seen there are 4 different heart sounds: S1, S2, S3 and S4. S1 is due to the closure of AV valve. What is AV valve? It includes the mitral valve as well as the tricuspid valve. Then S2 is the closure of semilunar valve. Semilunar valve indicates 2 valves. I already said in the cardiac cycle itself, that is the aortic and the pulmonary valve. Then when does S3 happen? Whenever there is a rapid filling phase and there is some vibration in the ventricles. That is the S3. And S4 happens whenever the atria is contracting and it is creating a severe vibration. Clinically, how will you differentiate between S1 and S2? I am not asking about the pitch, loudness and all. How will you identify which is S1, which is S2? So S1 is AV valve closure. Immediately after AV valve closure, what is happening? Cardiac systole is happening. So when systole is happening, we will feel a pulse. So whichever sound, heart sound, so you put your stethoscope on the chest wall and hear 2 sounds. And then put your one of the hands in the any of the pulses, preferably a carotid. Whichever pulse, whichever heartbeat is corresponding with the carotid, then that is S1. So this S1 corresponds with carotid. So this is important. Now coming to a beautiful diagram, what does it say? Suppose S1 is AV valve closure, S2 is the semilunar valve closure. What is the activity which is happening in between these 2 sounds? First, S1 is closed. So when S1 is closed, what is going to happen? It is going to contract the vessel. So whenever it is contracting the ventricle, what will happen? The blood is going to be ejected. So what is that? It is the systole. The event that is happening between S1 and S2 is nothing but the systole. The event which happens between S2 and the next S1, that will be our diastole. And if a diagram is given where the murmur is indicated between S1 and S2, that is a systolic murmur. And if the diagram is showing first S2, then they show S1, and in between them, for example, they draw something like this. This is a diastolic murmur. So from the question itself, you can easily identify whether it is a systolic murmur or a diastolic murmur, because systolic murmur will be between S1 and S2, and S2 and S1 will be the diastolic murmur. So this is very important. Now coming to the splitting of S2. Can the S2 be split? Because we told 2 valves are involved. Usually what happens is, this S1, the activity of mitral and tricuspid, they usually close at the same time, like 99% of the times. So that's why we hear only one sound. But some cases, what happens is, there can be physiologically also there can be a splitting of the second heart sound. The second heart sound is by which valves? It is by the aortic and pulmonary. Usually the aortic valve shuts faster than the pulmonary, because the pulmonary vasculation has a little less pressure, so it takes a longer time to shut the valve. So usually the valve sound is A2 and P2, and this physiological splitting is seen in one condition. Let's see now what is the splitting. So we are now going to understand various different types of splitting and what is the cause of each of them. So first, coming to the normal scenario, during an expiration, whenever expiration is happening, we generally don't see any kind of splitting. We just hear S1 and S2. Whereas during inspiration, whenever the patient is inspiring, let's assume suppose we are taking an inspiration. So what is happening? There is an increased venous return to the right atrium. So there is a right atrium increase in venous return. So what will happen? The ventricular filling also will increase. So now we have more blood. Actually, we are having more blood in the ventricle. If there is more blood in the ventricle, whenever it starts to pump, what will happen? The pulmonary valve will close a little late, because now in the right side of the heart, the volume is more. So it will take more time to pump it and finally to close. So the blood will be keeping on going it. By the time the aortic would have been closed, and finally it takes a little longer to close it. The pulmonary valve takes a little longer to close it. That's why physiologically also there can be a normal splitting between A2 and P2, that is the second heart sound, during inspiration. So physiological splitting happens during inspiration. Just remember this, it is very important. Physiological splitting. Now we are going to see various pathological splittings. So let's try to understand what is this pathological splitting. So there is one pathological splitting in these two diagrams. You can compare the above one is expiration and the below one is inspiration. In both of it, there is a splitting, and compared with the normal diagram, the splitting is wider. You can see here the splitting is wider, and compare the distance between them. The splitting distance is same in both of it. How does this can happen? There is one condition, one beautiful condition where this can happen. One is during inspiration also there is a wide split, A to P2. During expiration also splitting is happening, but there is no difference between inspiration and expiration splitting. This can happen in only one condition. Please remember it. It is the ASD. What is this ASD? It is atrial septal defect. This is the only condition where there is a fixed and wide split second heart zone, S2. Again, right? S2. How does this happen? So how does this happen? Let's try to understand. Why the splitting usually happens during inspiration? Because there is an increase in venous return. But right now we have an ASD. So what will happen? The excess amount of blood, if the pressure on the right side is more, what will happen? It will go to the left side. So the pressure gets neutralized. Then during the other cycle, like during the filling of the left ventricle, if it is getting filled a little excess and the pressure is more here, what will happen? It will move the blood to this side. So both during an inspiration and expiration, whatever the excess pressure is there, that will be equilibrated by this valve. So if the pressure is being equilibrated both during inspiration and expiration, do you think will there be any change in the splitting between them, like duration of A2 and P2? There will not be any change, because whatever inspiration extra blood is coming, that is being pushed, and whatever blood extra is coming for during expiration for the other side, that will be pushed to this side. So this valve is equilibrating the pressure between inspiration and expiration. That is the reason we don't see any kind of difference between inspiration and expiration, and it is a fixed split. Fixed split we will see only in this condition. Now coming to the next scenario, that is the wide splitting is there, but it is not fixed. When can this happen? This can happen. Normal splitting, now it is exaggerated. There is more splitting is there. Normally A2 is coming, then P2 is coming, but that has been increased. So what is happening? Either there is more volume in the left ventricle. So for example, if there is more volume in the left ventricle, obviously the time duration for closing the P2 will take a little longer. Or what could be the other reason? There is some pressure here, there is some obstruction here. So there also we have to push it against it, and it will take a longer duration. And then where else can it happen? The left ventricle is not, so right ventricle is not pumping properly. If the right ventricle is not pumping properly, then also it can happen. So what are the examples for this? Wide but not fixed. Either the right ventricle is having more volume or the right ventricle is not pumping properly. These are the two reasons. So what are the conditions? The first condition is, otherwise there could be one more condition also, one more interesting condition also. If there is a ventricular septal defect, there is a hole here, ventricular septal here. So whenever the ventricle tries to pump systole, the blood will come here and it will increase the volume here also. Again, whenever it is trying to push into the pulmonary artery, what is going to happen? There will take a lot longer time for the pulmonary valve to close. So the examples are VSD, that is a ventricular septal defect, or it can be a right bundle branch block. Right bundle branch block is there, or it can be a pulmonary hypertension. So or it can be a pulmonary hypertension. So in all those conditions, either the right ventricle is not pumping properly or it is having an excessive blood. So these are the conditions where there is wide but not fixed split is there. And one more condition where it can be there is pulmonary regurgitation. The pulmonary system is regurgitating the blood back into it. So what will happen? Whenever it is regurgitating, more volume is there and it will take longer duration for a P2. So it is wide and it is showing the inspiration and expiration changes also. Inspiration and expiration changes, usually it will be seen except for ASD. Then there is something called as reverse splitting. What is reverse splitting? Reverse splitting means usually A2 comes first, then P2 comes. Here P2 comes first, then A2 comes. Here it is being reversed. This reverse splitting, when does it happen? It is just the opposite of this. If my left ventricle is having more volume, or left ventricle is not pumping properly, or left ventricle has to pump against resistance, in all these conditions there will be a delayed closure of the aortic valve, which will cause a left a reverse splitting. So what are the example? Left bundle branch block. This LBBB is bundle branch block, RBB is right bundle branch block. Or there is a systemic hypertension. The patient is having hypertension. Then also it will take time. Or a aortic regurgitation. The blood is coming back. So what will happen for the next time? Next time the volume will be more and it will be pumping it for a longer duration. So the A2 comes delayed in these conditions. Now we will just summarize all our findings like the splitting. So the normal splitting when it is seen, it is during inspiration. I just want you guys to remember this chart, that is sufficient, but we should know the concepts before. So next thing is wide and fixed. Only one condition we have to remember, that is the ASD. Then wide but not fixed. It is VSD, right bundle branch block or pulmonary regurgitation or a pulmonary hypertension. Then coming to the reverse splitting. Reverse splitting is when left ventricle is having more volume or it is not pumping properly. That is LBB, that is left bundle branch block or aortic regurgitation or systemic hypertension. In all this condition, it is going to have a reverse splitting. In all this last condition, it is going to have a reverse splitting. So this is all about the splitting of the heart. Now we have to understand different types of murmurs, the systolic murmurs and the diastolic murmurs. Once it is done, our heart sound discussion is done. So coming to the murmur. What is a murmur? So basically, murmur means it is the abnormal sounds produced due to the turbulence. And it could be a systolic murmur or a diastolic murmur. First thing, tell me how will you identify it is a systolic murmur? If the diagram shows it is between S1 and S2, it is a systolic murmur. So this is a systolic murmur. And all these diagrams you can see it is S1, S2, S1, S2, S1 and S2. And there is some murmur which is happening in between them. There are three different types in this group itself. One is the ejection systolic murmur, then pan systolic murmur, then late systolic murmur. Ejection systolic murmur. So whenever the ejection is starting, there is going to be murmur sound. So what is the condition? As you can see here, this is an ejection systolic murmur. This is the diagram of an ejection systolic murmur. So whenever the ejection is happening, what is going to happen? The blood is going to go into the aorta. But if there is a stenosis, what will happen? It will create a gushing sound or a turbulence. So basically what is murmur? Whenever the flow is obstructed and there is turbulence, we will hear a murmur. So this ejection systolic murmur, where it can happen? It can happen in aortic stenosis. It can happen in aortic stenosis. Otherwise, the same thing for the pulmonary. It is pulmonary stenosis. Otherwise, where it can happen? Otherwise, in tetralogy of Fallot. In tetralogy of Fallot, pulmonary stenosis is one of the components. So, in tetralogy of Fallot also, it can happen. TOF. Then coming to the pan-systolic murmur. What is pan-systolic? Pan, the term indicates it is continuous. Pan means it is continuously happening during the entire systole. During the entire systole, we are hearing the sound. That is a murmur sound. So, the diagram that will be given is something similar to this. The diagram will be given which is spanning the entire area of the S1 and S2. So, where all it can happen? So, during a systole, whenever the blood is moving from here to here, in case of some defects from the left ventricle to the right ventricle, that can create a problem. That can create the continuous sound. Or the blood is continuously flowing from the left ventricle to the left atrium. There also it can produce the sound. So what are the conditions? Let's start to write it down. So first one is ventricular septal defect. Second thing is mitral regurgitation. Mitral valve is regurgitating valve. Mitral regurgitation. Or what is the other form? That is a tricuspid regurgitation. Tricuspid regurgitation. In all these events, it can happen. Then late systolic murmur. The initial part of systole is fine, but at the later part, there is a small murmur here. So this can happen in one condition that is called as mitral valve prolapse. There is prolapse of the mitral valve which is producing this late systole kind of murmur, mitral valve prolapse. So these are the systolic murmurs. So just remember the diagrams, then you can associate with the condition. So plan systolic means it should happen through the entire systole. So it means that it is connected to some other place, either the other ventricle or to the atria. Early systole is whenever it is trying to eject it, that time we are able to hear a murmur. So that is the stenosis conditions which is happening. Now coming to the diastolic murmurs. Now coming to the diastolic murmur, we have three groups in this also. Early diastolic murmur, mid diastolic murmur and late diastolic murmur. So these are the different three groups. And how will you identify it is a diastolic murmur? It is pretty simple. We have already discussed. We just have to know the S1 and S2. If it is showing S2 and S1, what is the activity going between them? The activity going between them is a diastole. So that will be the diastolic murmur. As you can see in the first diagram, it is an early diastolic murmur. So what is happening? In the early diastole, murmur is happening. So during diastole, the ventricle is starting to relax. Whenever the ventricle is starting to relax, there is a murmur here. How can it happen? Because if my aortic valve is not patent, it is going to regurgitate back. So if it is regurgitating back through the failed valve, it is going to create me a early diastolic murmur. So the question here is aortic regurgitation. And not only aortic regurgitation, the counterpart, that is pulmonary regurgitation. So both of this can cause a early diastolic murmur. Then coming to mid and late diastolic murmur, both of it are caused by the same conditions. There is a diastole which is happening. If it is early, aorta is giving the blood. But if it is late, now if in usually late murmur doesn't cause to the aorta. Why? Because it would have closed. Even though some blood would have leaked in the early part, then it would have closed. Usually late diastolic murmur is caused by the mitral valves, the mitral and tricuspid valve. So whenever there is a mitral valve, whenever there is a relaxation of ventricle, what is going to happen? There is filling of the blood from the atria. The atria is trying to fill the blood from the to the ventricle. So what will happen? If this valve is having some stenosis, it will be finding it difficult during the diastole. So what is the condition? So it can be a mitral stenosis. What is the counterpart of it? It is the tricuspid stenosis.